Okay,
Yeah, still one.
Item one.
Okay, not needing to pull out, but do we not have any quality minutes?
So we don't, because our SharePoint file is not acting correctly. Like, we can't get into it and access it appropriately, and it's matching information together between different hospitals. They're trying to get to the bottom of that. That's why we don't have any minutes, because that's what we put in to pull that stuff out.
So that you don't have to do that for any of these other reports then?
No, not through SharePoint, no.
Okay.
It's even messed up with Nick's schedule. He's had to have it completely reset for the nursing schedule.
Okay, well, just look, never mind, I guess we'd have to pull out two to talk about that, wouldn't I?
Mhm.
What, are we gonna go ahead and address one first?
Well, we gotta figure out which ones you
Okay.
want removed, that way we can approve everything else. So item one and two you want removed?
item 1, 3.
One. Oh, okay, one.
3,
Mm-hmm.
I didn't say three, so.
I said, yeah,
those, the only two you want,
Okay.
remove? Okay, so now we need to go ahead for the rest of it. So item 2, 4, 5, and 6.
So can we just have one question on it then, since we're ready to approve it? Or no?
So I think we need a motion
To
to approve.
approve items 4, 5, 2, 4, 5, and 6.
I'd make a motion to approve 2, 4, 5, and 6.
I'll second that.
if we could call for a vote at this time?
Lively,
Yes.
Ford,
Yes.
Van Zandt,
Yes.
West.
Yes. So now we'll go to item 1.
Okay, item one, we're gonna need to have the minutes corrected where it reads, it's under 14. Martinez explained that the hospital currently owns the van and that there is no resale value remaining on it. This will allow Siemens to pick up the van and use it as trade. The title will also have to be signed over to them.
It's a dimension analyzer. a
It's not the
chemistry
van.
analyzer. Yep, it's a dimension chemistry analyzer.
Good catch.
I'll get that changed.
So you're suggesting that change and approval with that change?
Oh, it'll have to be, I mean, that's not, yeah.
Well, that's, I guess, is that the motion?
Motion to approve item number 1 with that change.
Yes.
Okay.
Okay. I'd like to second that motion.
Lively,
Yes.
Ford,
Yes.
Van Zandt,
Yes.
and West.
Yes.
Okay, moving on to item number
3.
3, the clinic report. When it, just, quick question,
Yep.
what is a nurse visit?
A nurse visit is a patient comes in for, say, an injection or blood pressure check, which we really have discouraged those now because we don't see the charge for them, so.
Oh.
But, yeah, that's what it is. It's just a nurse checks a finger stick, but they still have a record of being there, that we did see them.
Okay,
That's what that is.
okay. And then, it says swing bed 5.
Uh-huh.
What does that mean?
So what that means is if our patient is established with us, if we have a patient swing bed status and they're established with our RHC, we get to bill that swing bed visit under the RHC visit.
Okay,
So it's not a cost on the hospital, it's a cost on
Correct.
the clinic. Provider, productivity, is that what the, why don't you just go through that and tell us what they all are? Total visits, provider produces, production.
Provider production, yeah. Total visits for July is 140. That is total visits that provider's seen the patients. Provider productivity was 152 because they look at his telephone information, like when he gets like somebody requesting something for a callback or something, they'll look at that. And then the RHC visits, again, that is patients that are rural health, Medicare, Medicaid that aren't
Any other questions on the clinic report?
Well, I did the math on, somewhere it told us how much was brought in, blah, blah, blah. But then later on, I saw where y'all did it. I actually had it as almost as 7 patients a day.
6.43.
Yes.
Yes, ma'am.
Okay, how in the world can we survive that clinic even, I mean, justify being open for 6 patients a day?
So we look for it to get busier, like we've been saying. I understand that Mr. Ogimbo has brand new to the clinics and to Mainland. His numbers are staying right around 10 to 12. His biggest day's been 14. He did have a previous day where he saw 10 clinic patients and, 12 clinic patients and 6 school physicals that aren't in these numbers. Because he's been doing the school physicals, they're cash paid up front, and they're community service. We do that as a community service. We're not making them check in and checking insurance or anything like that. We're trying to get him, he's still getting his feet comfortable in the clinic setting. We've reduced his patient time from 30 minutes still for a new patient, and he's now going to 20 minutes for an established patient. Eventually, we hope to get him to the 15-minute mark for established patients, and we can increase the productivity that way. We are also looking at increasing our marketing for him, and when Dr. Sandy gets here, we're gonna be increasing with that also with an MD in the clinic. But yeah, it's a good question. I mean, we are losing quite a bit of money every month for that clinic.
Who is setting the cap on how many visitors can be seen in a day?
Who's setting the cap? It just depends on what, like, how many patients. So say he's got a call for 5 new patients that day. That's gonna affect how many established patients he can see. But I will tell you.
So if I call the clinic tomorrow, will I be able to get in?
I have to look at the schedule.
But I'm saying,
Should
like,
be able to, yes,
but,
should be able to do this.
okay.
I
Just
mean-
by knowing his schedule, you should be able to.
So-
July is notoriously low volume
Yes.
for any clinic. I
Yes.
mean, the heat and just vacations and it's just downtime. It is.
So is it that he can't do a high volume, or is it that we don't have a volume to be able to?
A little bit of both.
Okay, so it's not just the fact that he can't,
No, it's a little
like
bit of both.
there is a volume he can handle.
Yes.
But we're also not even reaching that volume with the number of patients that are coming or calling and, okay.
Who is approving the denial of patients?
Any patients that get denied, if I get a phone call, I call the clinic and get them in. So it should be the clinic manager, this person, and the provider. If he feels that he has too many new patients on his schedule, it's the clinic manager and himself.
What about existing patients?
Existing patients, we try to get them in that day.
Do we keep any sort of log to how many people we're turning away a day?
I do not report it currently, myself.
I think that we probably need to start having a conversation about when they do turn people away, that an email needs to be sent that, hey, we received too many people today. We had to turn away this number, so we probably need to start keeping track of how many people are being turned away.
Okay, absolutely.
I start to say, if people don't even care, why are we turning anybody away with
Should
7,
be.
less than 7 a day?
We should not be. I don't disagree.
But, I mean, when I have to call the clinic manager every single time I need to get in there,
That is a concern.
and I'm being turned down every time.
I know when I get those complaints, I call the clinic.
But I'm saying, like, maybe we set up a policy to where, hey, we're at capacity, you get an email, the head of clinics gets an email that says, we're at capacity. And then, when you get that phone call, or Jeff gets that phone call, at least they have an understanding of why. And then if they are, you can be like, hey, we've seen 6 patients. Yeah.
Okay, absolutely.
And set up just a little bit of understanding of this is what capacity is.
When you get turned down, you're gonna go next door.
You are.
Well,
And you're
especially if
not
you
coming
don't.
back.
Sick.
Well, but I'm saying is the vast majority, at 99.99% of our people don't have the CEO of the hospital cell phone number or the head of clinic cell phone number to where they're getting in. And it also doesn't allow us to build our clients.
A lot of times the receptionist, and I have no idea who our receptionist is, but a lot of times they make themselves gatekeeper. I mean, you know,
They do.
you could see
They
that
do.
happening sometimes, so.
Most
But
of
I'm-
the times, that's where it's getting stopped. I will tell you, after extensive conversations with that clinic and that clinic receptionist, it's not coming from there. It's coming from sometimes feeling like, again, new to the clinic, I'm a little overwhelmed with 10 new patients. That's where it's coming from, a lot of the time. From me talking with the clinic, when I do get those phone calls, with the clinic manager and with the receptionist, why did we turn this patient away? We've got 6 patients this afternoon, why did we turn this patient away?
Yeah.
Well, the provider felt like he was getting overwhelmed a
Yeah,
little bit,
yeah.
so. I
And
mean,
that happens too.
It does,
Yeah.
it does
Every day.
happen, and we've had some conversations with him.
Man, that's
and
not good.
He knows the expectation of the board is 18. That is our break-even point, and he knows
But
that's the
I'm gonna
expectation
say,
of the board.
it is
And
very,
plus-
very disappointing
plus some.
when I've been turned away. I get squeezed in, I show up, there is no cars in the parking lot, there is nobody in the clinic, and I was turned away initially.
You know, part of that is your computer system and the documentation that they have to do for a new patient. And it is extensive, and if he's not familiar, I mean, you know, I'm just saying, I've had this problem before myself, the very same thing. And, you know, it's the provider gets overwhelmed. Is the expectation that he completes all of his charts daily? Doesn't have any outstanding?
He doesn't have to, but he has to complete them within that week.
With a new patient, you know, they have to go through everything and address everything.
And then if there's a referral, I mean, you gotta have
Yes.
that note done.
So, and I'm not saying it's right or good or positive, but it is a fact. But, you know, maybe he needs to have, what time of day did you call in? Was it morning?
I think you could call in at
Was it
any
morning?
point and not get in.
Morning.
That's what I
Yeah.
think.
If they try to spread out their new patients that aren't
Yeah,
ill,
different time, yeah.
acutely ill, and try to spread them out, then they ought to
So
have enough slots
is
in the
every
afternoon.
patient a new patient because he hasn't seen them yet?
No.
No.
Well, not anymore. Some of the patients he's seen every month, or, you know, repeat for, we put you on a blood pressure medicine, let's check in 2 weeks, that's not a new patient, so.
See, it's new to him, it's not new to the facility.
Yeah.
Okay.
That's the difference.
And that's the paperwork and stuff that
Yes.
goes on with the new
Right,
patient.
it's new to him. Mhm.
What's,
So-
And
cause
he's
I'm,
having to learn CPSI, so he's technically having to learn 2 systems, because we got ECW for the clinic, we have TrueBridge for our hospital, so all of his results currently from the lab are not interfaced with ECW. So he has to pull it out of CPS or TrueBridge or get a paper copy. We have recently shown him, because he brought this up in our conversation recently about getting more productive, what are we gonna do? He goes, I would really like to be able to see a graph, a trend of what my patients are doing. So we've we've shown him how to go into CPSI, run that report on each individual, say he wants to see your CBC the last 6 months, he can pull that now. We are also looking at an interface that will interface our radiology reports into ECW. Currently, he has to go in, find it in the scanned image, and I mean, a lot of people know, when you have a scanned image, it's
Right,
a
it's hard to
pain,
find.
you gotta go to a different area, pull it up, look at it. Sometimes it's the image, sometimes it's the report, or sometimes the report's not there yet, and he has to call the hospital and get it. So all of these things are kind of slowing him down. We are looking at the interface for the images and the radiology reads. The other stuff has already started, and the implementation is rolling on those, on the labs results going in. That should help.
What I see is if we're not able to get people in, you're not gonna have new patients to worry about needing an hour to put their information in or study over it. And if you can't get in and you're already a customer, they're not gonna come back either. So something's got to give here. It's gonna have to I mean, we're not in the first month. I
Yeah,
mean.
he's in his third, and that, we did his 90-day evaluation, and that's what brought some of this
Yeah.
up with us, talking with him, with this sit-down evaluation, we've gotta get to 18.
It's gotta get
We gotta
going,
get
and
to
you're not
18.
gonna get that by turning
And-
people away.
But just so y'all know, also remember Dr. Sand is coming this next month in September, we'll bring him to the September board meeting, so he can meet y'all also.
And that's the internist.
That's the internist, yes, ma'am.
Okay, so there will be no kids. He will not be seeing any kid, pediatrics, correct?
It depends on what he applies for credentials wise with the hospital I will get. And what y'all.
What do you mean? I thought you'd have to serve your time in that certain area.
On his residency, I'd have to look at his actual
Yeah.
residency on if he did a pediatric rotation. Most are internists, some do, some don't. It just depends on.
Oh, I thought most of them didn't. That's why they are an
Most
internist.
of them, you're correct.
Okay.
Most of them do not, but some of them do.
So if Carson brings his kids down there and this new one sees them and he doesn't have that, I mean, are we like held liable if something, I mean, is that not putting us in a bad position? I know you keep looking at him. Are you looking at him for the
I'm like,
answer or?
I mean, if his residency says he can see, if he's done pediatric residency and he's credentialed with the facility and with the board, and he's comfortable with that,
I mean, people take their kids to PAs and NPs all the time who didn't do pediatric residency, they did family or whatever.
I would imagine like ER and urgent care or
I mean, if it's not anything,
like pediatric endocrine, you know, or something like that, or new onset diabetes, probably not gonna touch that. But if it's a kid with cough, cold, you know,
Right.
he might be okay looking in the ear, different things like that. I don't think he's gonna be doing ADHD medicine through the 2-hour clinic or anything like that. You know, it just depends on what he's gonna be comfortable with doing under his license. But some of your interns, you are absolutely correct, will absolutely refuse to see children.
Yeah.
Yep.
do you allow the nurse to pull up, to get into that system and pull up the labs and
Absolutely.
try to have things
Yep. We
ready and
discussed
move that
also.
along? Okay.
At his 90-day evaluation, because he brought up some good points to help himself speed up, he really did. And that was discussed with the clinic staff that was there. The clinic manager has been out on PTO for a week and a half, so we'll discuss it with her when she gets back tomorrow.
Okay, I'd like to make a motion that we approve item number 3, the clinic report. We can call for a vote at this time?
Likely,
Yes.
Ford.
Yes.
Van Zandt. Webb.
Yes.
Yes. I just throw this out there, and I know we're off the topic, but I don't know that I've put in money to marketing if we aren't in a position to take in.
Well, we're willing to do that because we think Dr. Sanda's gonna be able, with his 4 days a week, we really and truly, with his comfort level, we're talking with him, and he's been working for Cohesive already, just not in our clinic. So he's seen ECW, he's been able to play with it, learn it for about around a month. So we feel like he's gonna be faster at it.
And I'm not disagreeing, I'm just saying, I think I would wait to see that we're not turning people away before we start spending money on marketing, so
Yeah.
then that just, I mean, that's just my thought.
Yeah.
Yeah.
Since that was brought up, the marketing that we see, and I know that's Facebook, so you're probably, well, you probably are having to pay somewhere for it to produce that. Do we have a nutritionist? Didn't they come down there? Can
We have a nutritionist that works for Cohesive, yes.
Okay.
Yes, we do.
But it's not somebody they're gonna walk into and get the advice straight up, right?
Not directly from the.
Same
clinic.
thing, how about women's health that's been advertised?
He can perform women, he's a family practice nurse practitioner, he is.
Oh, you're talking about the new one,
No, Dr. Nelson Okembo is a nurse practitioner.
and has had experience in that?
He is an FNP, so he's had to go through clinical for that, yes.
Wow.
He's
Okay.
had to do it.
Can only imagine that.
Okay.
Hey Cheryl, Mary Barnes has also offered, if, because she's worked in the clinic some, that if her services are needed for women's health, that she would be happy to help out too.
Okay, I think that'll make everybody feel a lot better. I think that service might be used if that's the case. I don't think, I
Yeah.
mean, you're gonna just blow money to the wind if, I just can't see women going there just for that. Now, Mary's there, yes. that might change things.
And I spoke with Dr. Fanda earlier today, and he is getting confirmation on his ability to see children. And he's supposed to let me know that tomorrow, so I'll pass that on to Kelly.
Well, when you say confirmation, did he have a residency at all with that? With pediatrics?
I don't think he had a residency in pediatrics, but he is going to see like what his limitations are as far as being able to see children in a clinic or an ER setting.
Okay. Now, as far as the MD part, I think everybody would have to be happy that we have an MD in town.
Absolutely, we haven't had one technically since Dr. Caleb.
Yes. So that part's good.
And he's gonna be here how many?
4 days a month, every other
Oh,
week.
a month, okay.
One day
Every
a
other
week.
week, 2 days.
Oh, 2 days in a
every
row.
other week.
I got you.
Monday and Tuesday. So, and his gonna be here the third because second, of course, is a holiday. Third, he's gonna be with Nelson, just kind of getting the lay of the land of the clinic, coming to the hospital and seeing us
So you're talking about next week?
next week.
Oh, okay, good.
And then the 16th, 17th is his technically first 2 days.
So we had at least go up to 14.
No, we better go up
On
more
a
than that.
couple of days.
Oh, we better go up more than that, sure. We'll see.
I know. Okay.
Is there any other remarks? Financial report?
Oh, hang, where'd he go?
Said he had to take a phone call.
Oh.
Hey, well, it's good to be back with you guys. I really appreciate Kelly and Dennis both helping to cover for me so I could spend time with my baby.
Bring a picture?
I do. I have plenty. All right, let's go
That's
over.
on the agenda.
Do it after.
It's all about family, health, baby health, pediatrics.
Yes. Okay, let's go over the financial summary for July. Okay, average daily census for the month was 10.48. That's down 2 days from June and down 1 from our year-to-date average. The acute payer mix for July was 84% for Medicare and Medicare managed care, with the prior month being 81%. This is also up from the year-to-date average of 78%. The swing bed payer mix for July was 82% for Medicare and 18% for Medicare managed care. And the year-to-date average for Medicare is 88% and Medicare managed care is 12%. The operating margin was a loss of $199,000, which is down $123,000 from June. Net patient revenue was $1.53 million for the month, which is an increase of $171,000 from June and down $68,000 from the year-to-date monthly average. The operating expenses were at $1.74 million for July, which is up $281,000 from the year-to-date monthly average. Patient days for July were at 325, which is a decrease of 37 days from June. Cash receipts for the month were at $1.34 million, which is an increase of $394,000 from last month. Cash disbursements were at $1.56 million for July. Our cash balance at the July month end was $734,000. That's giving us about 13 days of cash on hand. For the clinic, the July average visits per day were 6.43. Year-to-date revenue for the clinic was $203,000, and operating expenses are at $447,000. This is resulting in a year-to-date net loss of $245,000. Right now, if we continue at that, it's about a projected net loss of $419,000. Yeah, that is what I've got, y'all. Have any questions or concerns?
I do. When we look at month-to-date on page, let's see, 29, under expenses, we have salaries and benefits, we have contract labor. What on earth caused contract labor $712,751?
So Dennis and I dug into this a lot right before we closed for the month. And what we think happened is there were 2 missed accruals. while I was gone. So there were 2 invoices from Cohesive Staffing, which is our contract labor, that were causing some of it. There was also an increase whenever we switched in June to, like, a lot of the employees switched over to travel instead of in-house. So there's an
Okay.
increase that I kind of had to catch up.
Well, when you
from
look
being
at that, I
gone.
mean, we're way over $1 million
I know.
in personnel, basically, okay?
Yeah.
We don't have that much going on out there to be spending $1 million for personnel every month. And I just,
Yeah.
that's scary.
Yeah. Well, that
That
was a
can-
catch-up, and it shouldn't happen again.
And we're for sure that was what that was. It's
Mhm.
nothing else. It's-
Yes.
So if we
Yes,
go
ma'am.
back, so basically month before last, we should, what do we see? Do you have that in front
I
of you?
don't have it right in front of me, but I do have it on. Dennis, do you have that spreadsheet in front of you of what it should have been? Because I know we talked about it.
Yeah, it should have been, Cheryl, it should have been closer to 480,000. There's a couple of at least invoices that they missed. Now, the offset of that is our receivable last month for Medicare was 333,000. That's increased this month to 652,000. So almost, the good part of that, if we miss it on contract labor or anything else in med, it's almost all exclusively to med surge. So we actually have increased our receivable by 319,000 from where it was in the prior month. And anybody that would be looking at the trends, this is something that was easy to miss because there wasn't really anything that pointed out that we might have been under accrued. But we went back and just looked at, did some hindsight research, and Adrian had found a couple of invoices that should have been accrued, and they weren't. And then we had the shift, like she alluded to, from the people going from over to travelers. And so that kind of added insult to injury because it made those accruals that were missed large. Those are larger than they normally would have been. The only good part, again, most of this is that almost all of it's going to be 100% reimbursed.
So it's not 2 full months worth, it's just 1 full month and a partial month.
You're correct.
Okay.
It just seems very excessive to me, very excessive.
It was excessive in fairness, and when Adrian saw that, she immediately called me, so I helped her walk through it, and then we figured it out and what it was. What we're doing to be proactive, and it's something we should have done for the last few months, we also had someone else that was helping out to cover. I'm not trying to make excuses, but what we need to be doing always is calculating what our daily average is. That way you know for every month, like if you have a 31-day month, and you know what your average labor cost is per day, and you can do that as a test of reasonableness. So that's one of the ways that we could have helped minimize that. But we wouldn't have still, even if we had accrued an amount, we wouldn't have accrued that large of an amount to begin with. So it probably would have landed somewhere between it, but the actual for July should have been closer to 480,000.
Any other questions about the financial report? All right, item number 8, discussion possible action to approve using the Medicare receivable to pay $743,598.35 towards the ERS loan currently outstanding. The Medicare receivable paid off one of the ERS loans, however, it was paid to the facility instead of applying it to the second ERS loan. The only way to correct the error is to authorize applying the payment to the other ERS loan by issuing a check.
I have a request, and if you can't do this, that's fine. But if you remember some of the prior months, and this, go back, and again, if you have any questions, on our 2023 receivable, we had asked, and we talked to the board about just using that to repay Novitas, the outstanding ERS loan. For whatever reason, they went and they picked off the smallest loan, And then they gave us the money back for the larger loan. Well, we're paying 12.15% interest on that piece. So we wanted to go and just have them recoup what they had given us. So it would be paid down even sooner. And the target was, if we did this, that we might be able to be ERS debt-free by the end of the year. Well, in addition to that, so we currently have that money. In addition to that, then we received in August what they were projecting a part of this year's receivable. We are projecting right now through the end of July, $652,000. They paid us $516,000 in August. So now we only owe $970,000. That's the bottom line. And right now, with our cash situation, we could pay off and be ERS debt-free, pay off the entire balance that's owed. We would still have approximately 14 days cash on hand. And my recommendation would be, and it'd save us about $10,000 in non-allowable interest. So you can actually, in theory, pay it off today or next week and not have to worry about it for the rest and be ERS debt-free. I realize that's the amount, and the amount that was requested is because that's actually what they kept, or gave us back. But again, if there's an opportunity, or there is, in my opinion, an opportunity to just be ERS debt-free, if we can pay it off, that's what I would prefer. But whatever the board would like.
Can we?
What, Dennis, when did we receive that additional funds here in August?
It was like August, or somewhere around the first week, I believe right before the first week ended, or it may have been the second week, Corey, I had to go and check for sure.
About the only way you could approve to do the entire amount, we might be able to do it under new business. But that would be, so we'd basically have to do it twice. You'd have to approve this item, and then in new business, you'd have to
The difference.
do the additional, yeah.
Does it constitute as new business prior to?
Really?
I'm just asking.
I know, I'm just giving you a hard time.
I mean, why could we not amend, I understand approving this amount, but why could we not just amend this amount with new information?
Well, that's why I think we do it under new business, because we didn't have that information when they
When we post the
provided
agenda.
this agenda item. So this is a giant agenda item, is only allowing you to spend that title, that up to that amount. So with the new information, I think you can pay off the ERS loan, because originally, as the agenda item's written, and it was not intended to pay off the entire amount, just repay the money that was received. And so if we're going to be doing that, that's actually even different than what we were doing under this agenda item. So with the new information, I think it would constitute as new business, because this was not foreseen before we got here. And so I think you can probably do a motion under new business to pay off the ERS loan.
Would it be, again, I'm just asking, would it be simpler to table this one and just do the entire amount in a new business?
I think you take the action here on this one and then pay off the balance on the new business. I think you have to do both.
I mean, I think it's a good idea if we're saving that amount of money.
Mhm.
Yeah, I do too.
I mean,
Yeah.
so I'd make the motion to approve the request in item number A, the
I'll second it.
$743,000
Okay.
plus.
Call for the vote.
Lively?
Yes.
Ford?
Yes.
Webb?
Yes.
All right, number 9, discussing possible action to approve the ACH application between the Mangum Regional Medical Center and Amerisource Bergen for payment of pharmacy orders.
So AmerisourceBergen gave us some options when we were opening our account with them. We can do it two ways. We can prepay, this is for pharmaceuticals, this is for medications for us, or we can do an ACH every 2 weeks. Talking with Adrian, we elected to do the ACH every 2 weeks because the prepay, if our amount goes over, they're not gonna give us some items. This way, we'll be able to get all the items we order.
Yeah.
So, and we gotta have board approval for an ACH. So that's why we brought it to y'all.
So I'd make a motion to approve the ACH application.
Is there a second?
I'll second that.
Call for the vote.
Lively,
Yes.
Ford,
Yes.
Webb.
Yes.
All right, item 10, discussion possible action to approve the AT&T Business Telecommunications Service renewal for the hospital internet services.
Mhm. So AT&T reached out to us and given us an option to decrease our total cost per month. If you look at that, it's right around $900 per month with the renegotiation of a 36-month contract with no termination for fiber internet. It gives us a static IP address and dedicated router for us. And it's a one-time installation or a $150 installation fee.
What are they installing that they're?
You know, who knows with AT&T?
Well, I'm just wondering if we're just renewing our service. What are
We're
they
just renewing, it's something with the static IP address. Chad would have to tell you exactly what it is. He was the one working with the AT&T business guys.
But it's still a savings of about $750.
Yeah. And it'll go into effect this month. I mean, it's with that signature on that.
I'd make that motion.
Is it-
Second.
Call for the vote.
Lively,
Yes.
Ford,
Yes.
Webb.
Yes.
Number 11, discussion possible action to approve the ODOT's Title VI plan and other 5310 grant items associated with the transport ban that was previously approved at the June 2024 meeting.
So, ODOT, we all approved to go for that grant for our van, for the Strong Minds program. But the van will also provide transport, can do transport for the facility. They were not happy with what the minutes said, saying, yes, we wanted to apply for the grant. They wanted y'all to review the plan that y'all see in front of y'all and approve, put in the minutes that y'all approved the plan that we supplied to them, that the board did. Not it was coming from me or any, they wanted it to come from the board saying, yes, we approve this plan. So we had to bring it back to y'all, shows y'all the entire plan we're looking at for our facility.
And this is the grant application.
This is the
basically.
grant application for ODOT, yes, for the 5310 Title IV application, yes, sir. It spells out how we're gonna use the van, what we're gonna do with it, our radius, how we're gonna, I mean, it goes even to like community committees, I mean, minorities and all that. I'm going, really? I mean, they wanted us to get really deep.
Is there a motion?
Hang on, I'm still. Well, somebody can make a motion.
It's a lot.
So you just want a motion that says.
That y'all
the board
approve the
has,
plan.
Has viewed the.
Reviewed and approved the plan.
Application and approved that plan?
Yep.
Okay, well, I can make that one.
Is there a second to that motion?
I'll second that.
Is there further discussion that we need?
I wasn't here in June to know the actual section.
They approved to get it.
They,
I've not been in the,
ODOT.
locking of the van business the whole time.
ODOT is, if we get approved for the grant, ODOT will reimburse Mangum Regional Medical Center 85% of the cost of the van.
Cool.
So the van we're looking at, but it has to be a brand new van. The van we have supplied so far, the first quote is a 12-passenger, 2-wheelchair with a lift for right around $130,000. But that's our first, that's just the initial one. That's with no bargaining back and forth. That's just what we had to supply them in an initial quote. And then once we pay for it, we'll supply the sales invoice to them, and then they'll reimburse us 85%.
So what's the law for the grant? So sometimes they require you to keep the items for a
yes.
period of 5 years or longer.
I think it's 5 years.
Okay.
I really do.
Because I know a lot of times they put those
Mhm.
caveats in there, and so if we figure out that this isn't something that benefits us, we'd have to wait 5 years to.
But to sell it.
Yeah.
And yet again, We can use the van for transport of our hospital patients to the clinic,
Yeah.
picking them
Well, I
up,
think
bringing
it's a
them.
good idea.
Yeah,
Take them to the nursing home.
take them to the nursing home, you know, lots of things. We can do lots of things with the van. It doesn't specifically, we initially we're gonna do it for Strong Minds, but we have to do it not just for that, for other also, according to the grant.
Because we were gonna have to utilize that for Strong Minds, or do something for
Yes.
Strong Minds anyway.
Yes, we were.
I
Further
did
discussion?
second.
Huh?
I did second.
Yeah, so is there
Okay.
any further discussion?
Make sure you have air conditioning in it.
It's be a brand new
Call
van,
for
it
the
better
vote.
have air
I was gonna
conditioner in
say,
it.
for that price, wow.
Call for the vote.
Yes.
Ward.
Yeah, you do
Yes.
too.
Webb.
Yes, it's the air conditioners roll down the windows.
Big screen.
Item number 12, discussion possible action to approve the first digital service order agreement for clinic fax line services.
So currently, we have AT&T. They're $135 a month for one fax line at that clinic. I mean, we pay right around $1,000 at the hospital for our fax line. But it's gonna go down to $9.50 with First Digital.
Is it that just $9.50?
$9.50.
Nothing per page?
$9.50 monthly.
How much I pay fax service?
Yep, it's not a per page. That's the actual printing company that we have for papers that are printed out on that. That's with Stanley.
So it'll run through the copy machine?
Mhm.
That's what I have too.
Yep.
Mine goes to my email.
Yeah.
Mhm.
Nobody ever faxes.
I was gonna say, we use the email fax
It's so much
service
easier.
now.
It's so much easier.
My fax service goes to my email.
That's how ours does
Mhm.
now,
Okay.
because we don't have local offices, it sends it
Yeah.
straight to our emails, as opposed to going to a fax machine. And I don't know what the cost of that is, but I'm sure it's,
Well, mine's $10, around $10 a
Yeah.
month.
Our faxage through CPSI to get stuff to our email is $7.50 a month for us at the hospital through TrueBridge. So that's all we pay,
just $7.50?
just $7.50 through TrueBridge.
Why aren't we doing that instead of this?
Because it won't go through TrueBridge, because we don't have TrueBridge down there. We got ECW.
I'd make the motion to approve this.
Is there a second?
I'll second it. Look at
Call for
y'all
the vote.
saving us money.
I'm telling you, we're trying.
Lively.
Yes.
Ward.
Yes.
Webb.
Yes.
Y'all could thank Chad for all the savings. Chad's been working really hard
Item
in IT.
13 is credentialing, there's none listed on the agenda. So item 14 is unneeded. Is there any staff or board remarks? Hearing none, is there any new business?
I think we bring up the paying off the additional parts of that loan.
Is there a second?
Yes. Oh, yeah.
Call for the
We
vote.
all agree on that.
Lively.
Yes.
Ward.
Yes.
Webb.
Yes.
Is there any other new business? Is there a motion to adjourn?
I'll make that motion.
Is there a second? Call for the vote.
Lively.
Yes.
Ward.
Yes.
Webb.
Yes.
We are adjourned at 5:47.
Thank you, guys.